Electrocardiography is the graphic recording of the electrical activity of the heart. It is an important diagnostic tool for diagnosis of cardiac diseases, particularly myocardial infarction, various conduction defects, and arrhythmias. It should be kept in mind that an electrocardiogram is not a final parameter for the diagnosis of heart disease. A person with severe heart disease may have normal electrocardiogram, while a normal person may show non-specific changes in ECG. Therefore, the diagnosis of cardiac disease, disease and electrocardiogram should be interpreted with the clinical history, age, sex, weight, drugs being used, and associated clinical conditions. The SA node is the physiological pacemaker of the heart. It is located in sinus terminalis in the upper part of the right atrium near the entry of superior vena cava. It has the capability of producing electrical impulse of 100 to 150 millivoltage at a rate of 60 to 100 per minute. This impulse passes downwards to the AV node, which lies in the right side of the interatrial septum in the lower part of the right atrium below the coronary sinus through three internodal tracts, anterior, middle, and posterior. The AV node continues downwards as bundle of his along the right side of the membranous part of the interventricular septum to the muscular part where it divides into two as right bundle branch and left bundle branch. The right bundle branch supplies whole of the right ventricle while the left branch pierces the interventricular septum, enters the left ventricle where it divides into two anterior and posterior branches. The anterior branch supplies the upper and anterior part of the left ventricle, while the posterior branch supplies the inferior and posterior part of the left ventricle. These bundle branches finally ramify into Purkinje fibers, which merge into the muscles. The cardiac cycle at rest is positively charged outside, that is in the cell membrane, and negatively inside, with the resultant electrical potential of zero. When electrical impulse arrives from synovial node, it depolarizes the proximal end of the cell, which becomes negatively charged. The electrical impulse passes from the negative proximal end to the distal end, which is positively charged. Movement of this electrical activity is if recorded by a galvanometer, putting an electrode on the distal end, a positive deflection is produced on the recording paper. But if the electrode is put on the proximal pole of the cell, a downward deflection is recorded, and if the electrode is put in the center of the cell, a biphasic deflection is produced. This is the basis of electrocardiography recording. The electric impulse, while passing through the cells, has an amplitude and a direction, and there it is known as a vector. Millions of vectors pass through heart and converge towards the main bulk of the heart. The mean of these vectors is known as axis of the heart. The electrocardiogram is recorded by means of 12 leads. 6 leads are limb leads and 6 are chest leads. The limb leads record the electrical potential in frontal plane, while the chest leads record the electrical potential in horizontal plane. The limb leads are three are bipolar and three are unipolar. Out of the unipolar, lead 1 records electrical potential between right arm and left arm, Lead 2 records the electrical potential between right arm and left leg. Lead 3 between left arm and left leg. While the unipolar leads lead AVR from right arm, lead AVL from left arm, and lead AVF from left leg. The chest leads are, are termed as V1 to V6. They are placed on the chest wall to record the electrical potential in horizontal plane. Limb leads, bipolar limb leads. Lead 1, resultant of right limb and left arm, right arm and left arm. Lead 2, resultant of right arm and left leg. And lead 3, the resultant of left arm and left leg. The chest leads are placed on the chest and are known as V1 to are labeled as V1 to V6. V1 lead is applied in the third intercostal space on the right side of the sternum, while lead 2 in the third intercostal space on the left side of the sternum, lead 4 in the mid clavicular line, and 3 in between 2 and 4. Lead 5 is in the mid axillary line, lead 6 in the middle axillary line. As I said before, that electrocardiogram can be recorded in through planes: frontal plane by the limb leads, horizontal plane by the chest leads, sagittal plane is rarely used. To calculate the heart rate is very easy to calculate the heart rate. If you count the small squares, 1 millimeter squares between two complexes, RR waves, and divide 1500 by that number, the pulse rate will come. For example, there are 21 small squares between two RR waves. If we divide 1500 by 21, it comes to 71. The heart rate is 71. But if the rate is rapid and irregular, then we have to take a long strip of electrocardiography paper, long strip of 6 seconds, and 6 seconds that needs 30 big squares. 30 big squares are equal to 6 seconds. And we count the cardiac cycles in these 6 seconds. These are 19. If we multiply 19 by 10, then that comes the heart rate in 60 seconds. And here it is 19 to 10, 190 per minute. As I said, the heart rate can be calculated by dividing 300 by the number of big squares and 1500 by small number squares between two RR waves. For example, here between two RR waves there are three big squares. So 300 divided by 300, 100. Likewise, 15 small squares, and if we divide 1500 by 15, it comes 100. So we have to divide 300 by big squares and 1500 by small squares. Normally, the axis of the heart lies between 0 and plus 90. From 90 to plus 180, it is right axis deviation, and from 0 to minus 90 is left axis deviation. The axis deviation can be easily calculated by just sieving the limb leads, phono 1 and AVF. If it is the maximum deflection in one is up and in AVF it is also up, it is normal. But the maximum deflection in one is up and down in AVF, it is left axis deviation. And if it is down in one, down in one and up in left AVF, it is right axis deviation. Exact axis deviation can be mathematically calculated by getting the algebraic sum of the positive and negative electrical potentials in lead 1 and 3. For example, in lead 1, the positive potential is 5 millimeters and the negative downwards is minus 2. The resultant will be plus 3. Plus 3. Here, the positive potential is plus 6 millimeters. The negative minus 2. The resultant algebraic sum is plus 4. If we plot these 3 and 4 on the axis of lead 1 and lead 3 in the hexagram, as I show you here, the 3 millimeters is plotted on lead 1, axis of lead 1, and 6 on lead 3. Then perpendiculars are drawn from this lead 3 and lead 1, perpendiculars, and the point where the perpendicular meets is connected to the center of the hexagram. This is the axis, exact axis of the heart, which is nearly about 6 degrees, 60 degrees. Normal electrocardiogram regarding of the limb leads and the chest leads. In limb leads, these upper are the limb leads and these are the chest leads. In limb leads, the maximum deflection is upwards, except AVR, where it is downwards. In chest leads, the R wave goes on increasing from V1 to V6, while the S wave regresses from V1 to V6. Again, chest leads showing R wave progressively increasing and S wave regressing from V1 to V6. Now coming to the fundamentals of the electrocardiogram, we will talk about the electrocardiography paper and then about the component of the ECG. The electrocardiography paper contains two small squares. One is 1 millimeter square, 1 by 1 millimeter. Other is big square, 5 by 5 millimeters. The horizontal line represents the time and vertical line represents the electrical activity in millivoltage. The 1 millimeter is equal to 0.04 seconds. 1 millimeter horizontally is equal to 0.04 seconds, while 5 millimeters are equal to zero point 0.2 seconds. Zero point 0.2 seconds. And 300 such big squares are equal to 300 are equal to 1 minute. Likewise, 1500 small squares in horizontal direction are equal to 1 minute. 1500 small squares and 300 big squares horizontally are equal to 1 minute. Horizontally, 1 millivoltage is represented by 10 millimeters of height in vertical direction. 10 millimeters in vertical direction represent 1 millivoltage. The paper of ECG rolls at a rate of 25 millimeters, 25 millimeters per second. The paper rolls at the speed of 25 small millimeters. So 25 millimeters in 1 second and 1500 small squares in 1 minute and 300 big squares in again in 1 minute. Now talking about the normal electrocardiogram, the first elevation is P wave, which is due to depolarization of the atria. Then comes Q wave, which is due to depolarization of the interventricular septum. Then R and S, which is due to depolarization of the ventricles. It is followed by another wave, T wave, which is due to repolarization of the ventricles. Then U wave, which is repolarization of the Purkinje fibers. This P wave, duration of P wave should not exceed 0.11 second in duration, and it should not exceed 2.5 millimeters in height. Likewise, the PR interval is from end of the P to the start of the Q. It should be between zero point 0.12 seconds to zero point 0.2 seconds. Then the Q wave should not exceed 0.04 seconds in timing, that is more than 1 millimeter. Should not exceed in width more than 0.04 seconds, and its depth should not be more than 1/4 of the R wave. It should not exceed 1/4 of the height of the R wave and 0.04 seconds in duration. The QRS, which is due to depression of the ventricles, the time should not exceed more than 0.1 second. Then comes the ST segment, which is at the end of the S and beginning of the T, and it is more or less isoelectric. Then the T waves, which is due to repolarization of the ventricles, and then the E wave, which is U wave, which is due to repolarization of the Purkinje fibers. The P wave, as I said, it should not be more than 0.11 second in duration and more than 2.5 millimeters in height in limb leads and 1.5 millimeters in pericardial leads. The PR segment should not be more than 0.12 second to zero point 0.2 seconds in duration. The Q wave represents the depolarization of the septum and should not be more than 0.04 seconds in time and 1/4 of the height of the R wave. QRS complex is due to depolarization of the ventricles. Both the ventricles are depolarized simultaneously and its timing should not be more than 0.1 second. The ST segment is that portion of the ECG which lies between the end of the S wave and the beginning of the T wave. The ST segment blends smoothly with the T wave and is normally isoelectric. The T wave is due to depolarization, repolarization of the ventricles and, and it is normally upright in lead 1 and 2, inverted in AVR. T wave in children up to 14 years and is commonly present. T wave inversion is commonly present in lead 1 to 4 in children up to 4 years of age. U wave, as I said, is due to depolarization of the Purkinje fibers. QT interval from the beginning of the Q to the end of the T, and it is actually related to the pulse rate, and it is corrected by the nomogram according to the pulse rate, and corrected QT interval is known as QTC, QTC, and it should not exceed more than 0.42 seconds.